Very good afternoon, doctors. Topic for today's discussion is IVF card. So coming to what is an IVF card, it is the stimulation card once you start IVF stimulation for a couple. So what are the details you're supposed to note down in that, and what is the progress that you note down in that, we will be seeing today. So coming to this IVF card, so the preliminary details will be pertaining to the name of the female partner, age. Age gives us an idea of the estimated ovarian reserve and oocyte quality. Marital life and whether that is a consanguineous marriage or not has to be noted. Along with that, the BMI of the female partner has to be noted, which gives us an idea on how much dose to start for that particular female partner. Coming to the menstrual history, we have to note down the length of the cycle, whether it is a short cycle or a long cycle, and if there is any amenorrhea has to be noted. This gives us an indication if the woman is having a shorter cycle, say suppose 24-25 days cycle. In such cases you can get an estimate of the ovarian reserve. On the contrary, if the cycles are irregular or the patient is having amenorrhea, then you can expect a PCO picture in such case, and based on that we can plan the dose accordingly for that particular stimulation cycle. Coming to the baseline investigations which have to be noted in the female partner. At the start of the stimulation, we have to make a note of serum estradiol and progesterone concentrations. Along with that, FSH, LH, baseline AMH, TSH has to be noted, and fasting serum prolactin in selected cases where there is amenorrhea coupled with galactorrhea or visual disturbances, serum prolactin levels has to be mentioned. Along with that, viral markers have to be mentioned specifically. And if there are any reactive cases, such cases have to be processed, and the cryopreservation of such cases has to be taken care accordingly. Other investigations include blood grouping and typing, which gives us an idea of whether the woman can land up in a RH complicated pregnancy in future. HbA1c, renal function test, liver function test, and complete blood picture have to be made a note of. Now coming to the preliminary details of the male partner, name, age has to be noted, and along with that, any addictions have to be noted and BMI have to be noted. Coming to the baseline investigations which are to be done in the male partner, these include the viral markers, which gives us an idea about how, excuse me. So coming to the preliminary investigations which are to be done in the male partner, these include the viral markers, HbA1c, TSH, and blood grouping and typing. Along with that, the initial semen analysis parameters have to be noted pertaining to the concentration, the progressive motility, and the normal forms. In case of severe oligoasthenoteratospermia or azoospermia, karyotyping of the male partner, along with that Y chromosome microdeletion, especially if the concentration is less than 1 million per ml, FSH, LH, estradiol, total testosterone, prolactin, ultrasound scrotum, and Doppler are to be noted in cases of azoospermia, and severe oats. Sperm DFI is to be noted in selected cases, especially in those cases with previous failed IVF cycles, repeated miscarriages, advanced paternal age, especially if the male partner is more than 40 years of age, and in cases of unexplained infertility. Medical, surgical, and sexual history pertaining to both the partners has to be made a note of, and if any underlying medical conditions are there, then they have to be corrected appropriately before starting the stimulation cycle. Obstetric history, if any, has to be noted. Previous fertility treatment history is to be noted in detail, especially the stimulation protocol and chart in case there is any previous cycle of IVF. And the TBS findings of the current cycle, if there are any endometriotic cysts, and the accessibility of the follicles for oocyte retrieval in case there is an endometriotic cyst, any adherent ovaries or tubo-ovarian masses, and any intervening subserous fibroids or pedunculated fibroids are to be noted. Prior hysterolaparoscopy findings, if any, pertaining to the same ultrasound findings like adherent ovaries or tubo masses or any fibroids have to be noted. These give us an idea on how to proceed for oocyte retrieval in complicated cases. Coming to the other side of the stimulation chart, which includes the name and the preliminary ID details of the couple, and the diagnosis, the indication for which we have planned IVF, whether that is a tubal factor or an endometriosis, which is severe endometriosis, or mild or minimal endometriosis, wherein the first line treatment of IUI cycles have failed for 3 to 6 times, or it is a case of PCOS where it is anovulatory in spite of second line therapy of gonadotropins or laparoscopy, or a case of PCOS wherein multiple cycles of OI have resulted in ovulation but failed to result in a pregnancy. It can also be a case of unexplained infertility and advanced maternal age, or a male factor infertility, and also in those couples who carry autosomal or sex-linked genetic disorders or balanced chromosomal translocations, wherein PGT, pre-implantation genetic testing, is performed. In such cases also IVF-ICSI is indicated. So coming to the treatment plan, what exactly are you planning for the couple? Whether it is conventional IVF or an ICSI cycle, and the source of the gametes, both oocyte and sperm, are to be noted after confirmation with the couple, and consents are to be obtained appropriately, especially if it is a case of donor gametes. Semen preparation method has to be made a note of once the stimulation starts, whether it is density gradient method or microfluidics, which is used for semen preparation. In case it is a case of azoospermia and surgical sperm retrieval is planned, whether it is a PISA, TISA, or TESI or micro TC, it has to be decided once the stimulation starts. And any PGT, if it is planned for the couple, it has to be noted down in the stimulation chart, and the indication for PGT has to be mentioned clearly, and appropriate PCP and DT forms also have to be filled, and it has to be notified to the certain authority. So coming to the protocols of ovarian stimulation, it is always an individual controlled ovarian stimulation approach. Why? To achieve optimal number of good quality M2 oocytes, to get a fair chance to have more number of good quality blastocysts, so that we can have embryos for future embryo transfer in case the pregnancy doesn't happen this cycle, and also to reduce the risk of OHSS, to reduce the chances of cycle cancellation, and to increase the pregnancy rate when we have more number of frozen blastocysts, and to reduce the financial burden to the couple, individualized control ovarian stimulation is preferred. In some cases, how much ever we individualized, say suppose in 10 to 20% of the cycles might land up in poor ovarian response. So coming to the protocols which are used, the most common gold standard protocol which is used is antagonist multi-dose flexible protocol, wherein we start with gonadotropins on the cycle day 2 or day 3, and then antagonist citrorelix 0.25 mg subcutaneous is added once you see a dominant follicle of 14 or more. In fixed regimen, the antag is added from day 6 or day 7 of the stimulation, irrespective of the size of the follicle. On the contrary, there are single dose antag protocols also. Coming to the next commonly used protocol, which is nothing but the long agonist protocol. The long agonist protocol particularly is used in those cases with asynchronous cohort. So the long agonist protocol provides a better synchronization of the follicle so that more number of mature oocytes can be retrieved and more chances of embryo formation will be there. So in long agonist protocol, we will start daily injection of agonist, especially in those with regular cycles. We start from the day 21 of the previous cycle, 1 mg of leupride, which is continued till cycle day 1. And cycle day 1, based on the scan, gonadotropins are started from day 2 of the cycle and the dose of the agonist is halved, which is continued till the trigger. So both the gonadotropins and the agonist are continued till trigger is given. And in agonist cycles, we can give only HCG trigger. We can't give an agonist trigger. So we have to go for a milder stimulation protocol wherein we are expecting lesser or moderate number of oocytes. Next comes the short agonist or the flare protocol. Other alternative is microdose flare protocol, stop protocol, ultra short protocol. All these are other types of agonist protocol. Coming to natural cycle IVF, which is very rarely done because of increased cancellation chances due to premature LH surge and the outcome being limited wherein 1 or 2 oocytes are retrieved. So based on the hormonal evaluation and the ultrasound findings like estradiol and LH concentrations and ultrasound findings, the patient is scheduled for oocyte retrieval and planned accordingly. Coming to modified natural cycle, wherein we give a trigger. In natural cycle, we won't give a trigger injection. In modified natural cycle, we will give a trigger injection, and sometimes GnRH gonadotropin antagonist might be given along with gonadotropins to schedule the case. Milder stimulation IVF is currently being used these days, especially in those with poor ovarian reserve. So in such cases, the patient is started on oral oval agents and lower doses of injectable gonadotropins, say suppose 75 or 150 international units of HMG, which are started alternate day or daily. Along with that, antagonist is added as per the routine protocol wherein one dominant follicle reaches 14 or more, and that is continued till the day of trigger. Coming to dual stimulation protocol, this stimulation protocol is particularly used in those who have limited time, especially in those with malignancies where oocyte cryopreservation or embryo cryopreservation is planned before going ahead with oncotherapy. The next protocol is progesterone primed ovarian stimulation. This has an advantage wherein the cost is cut down and the pain of multiple injections of agonist and antagonist is cut down. Then in PPOS, the progesterone is started either on day 2 or day 3 along with the gonadotropin, or in flexible PPOS protocol as in ANTAC protocol. Once you see a dominant follicle of 12 to 14 you can start your progesterone accordingly. So these days we are hearing a lot about random start protocols. So what exactly are these random start protocols? So in conventional cycles of stimulation, we start the gonadotropins either on day 2 or day 3 of the cycle. But in random start protocols, irrespective of the cycle, like say suppose in those with PCO with irregular cycles, you need not wait for her to get the cycle. You can just do an ultrasound, and if you find follicles are synchronized and the largest follicle is less than 10 mm in size, then you can straight away start the stimulation irrespective of the cycle. But in such cases, a careful ultrasound examination to look whether there is a corpus luteum or not is more important, and hormonal evaluation. Along with that, at the start of the stimulation, it is always better to do a urine pregnancy test or a serum beta HCG test along with progesterone. And the progesterone and beta HCG are to be repeated intermittently in the cycle based on the cycle response, and mandatorily before the trigger, progesterone and beta HCG are to be repeated. So one of the dreaded complications of this random start protocol is that some cases early pregnancy might be missed, and unfortunately in cases where it is an ectopic pregnancy, the situation will be very scary to handle both for the consultant and the couple. So what are the gonadotropin preparations that are used for ovarian stimulation? So coming to urinary preparations, they are HMG and HPFSH, and the recombinant preparations like recombinant FSH, which includes various patented molecules and biosimilars nowadays available in India, and Pergoveris, which is a combination of recombinant FSH and LH in the ratio of 2:1. These are the commonly used gonadotropins for ovarian stimulation currently. So what is the starting dose that has to be put up for a case of ovarian stimulation? In books, we see somewhere around 150 international units for a case of PCO, but as per the studies conducted on the Indian population recently, 225 international units is the minimum required starting dose for ovarian stimulation in Indian population. And the maximum dose can range up to 450 international units, beyond which no benefit has been documented either in the number of oocytes or on the quality of oocyte. So the initial starting dose has to be decided based on the age, ovarian reserve, and BMI, especially in those with elderly age more than 35 years and those with previous cycle showing poor ovarian response. A component of LH has to be added so that we will have a better ovarian response. In case of a repeat cycle of IVF, protocol and dose are to be decided based on the previous cycle dose and the outcome. So what are the triggers that are used in ovarian stimulation? HCG, which is urinary preparation, 5,000 to 10,000 international units can be used. Recombinant HCG, 250 micrograms can be used as a trigger. On the contrary, in those cases where the pre-trigger estradiol is more than 3,500, or in cases where there are more than 10 follicles greater than 12 mm, in such cases, agonist triggers are safer to reduce the risk of OHSS. Be careful, in some cases, you might feel the dominant follicles are less, but in such cases, if the intermediates are in greater number also, though they also contribute to serum estradiol, and such cases might land up in OHSS without our notice when HCG trigger is given. So whenever you are giving HCG trigger, be very careful, monitor your scan carefully and your serum E2 levels, and then decide trigger. So agonist triggers which can be given include leupride, which is 0.5 or 1 mg, triptorelin 0.2 mg, buserelin 0.5 mg can be used as triggers. So if any pre-treatment is given, like oral estrogen for synchronization of the follicle, or testosterone gel, especially in those cases with diminished ovarian reserve, or coenzyme Q, these are to be noted in the stimulation chart. So this is one more example of a stimulation chart wherein the preparation of gonadotropin like HMG or FSH or pergoveris, what is used exactly, and we have to mention units of dose daily given to the patient. And whenever the antag is added, we have to mention the dose of antag and from which day it is started, that has to be mentioned. And hormonal evaluation at the start of the cycle and day 5 or day 6 of the cycle and before trigger are to be noted. And those who are more confident with their scan findings, they rely less on the hormonal findings. So it's always up to you, like which method you want to choose. And this once the cycle for stimulation starts, we have to make a note of the follicles and the sizes. Say suppose if there are 4 follicles of 5 mm on the right and the left, we have to make a note at the start of the stimulation. Then whenever the scan is done on the 5th or 6th day, you have to make a note of the size of the follicles in the right ovary and the left ovary. There might be 12 mm follicles, 4 in the right ovary, it has to be noted down, 3 in the left ovary, they have to be noted down. So the folliculometry has to be specifically and accurately noted, and the trigger day depends on the size of the follicles on the scan. So this is the cycle day 1, day 2 accordingly, and the folliculometry findings of the left and the right ovary, and the sizes of the follicles correspondingly, and the endometrial thickness whenever the scan is done. These are to be noted accordingly. And this is a case of ART summary, like at the end of the cycle of IVF. So what is the source of the semen, like partner ejaculation or donor sample have to be noted, and the egg retrieval date and time are to be noted. And what is the method, whether it is conventional IVF or ICSI, and the number of oocytes are mentioned here. And the semen parameters of the semen sample on the day of egg retrieval, they have to be noted, pre-processing and the post-processing. And this are the eggs that are retrieved, wherein 3 eggs are retrieved and all of which are mature oocytes, on which ICSI is done with the partner sperm, and then day 1 fertilization check, 16 to 18 hours post ICSI, then day 3 and day 5. So on day 5, single blastocyst is formed for this particular case and it is frozen. So this is how an ART summary looks at the end of an IVF cycle. So let us discuss some of the case scenarios. This is about a 28-year-old female. She is married to 30-year male with a marital life of 5 months. She visits your OPD and is planning for pregnancy. Do you evaluate her or no? So whenever a couple comes to you, even with a shorter marital life, but they are planning pregnancy, they have to be evaluated. You can't tell like you are less than 35 years, you are hardly 5 months of marital life, come back to me when you are 1 year or so. So these days with the increasing trend of diminished ovarian reserve and abnormal semen parameters, always whenever a couple comes to you, young couple with a shorter marital life planning for pregnancy, it's our responsibility to do a basic evaluation for them and advise them accordingly. So this particular couple, if on basic evaluation, the semen analysis shows a concentration of 10 million per ml and a motility of 15% with a normal form of 2%, how do you proceed further for this case? So since this is their first semen analysis, you can just put them on a couple of antioxidants and repeat the semen analysis after 1 month and see how it is doing. So always the semen analysis, if it shows a mild or moderate abnormality, it has to be repeated after 1 month, and then based on that report only, decisions have to be taken pertaining to the treatment. So for this case on TVS, if I see AFC2 on the left side and AFC2 on the right side, what do you do for her? In such case, if the couple is planning to postpone the pregnancy for further later, or the couple is planning for a family with 2 kids or more, then in such cases, for this couple, after confirmation with AMH, then it is better to advise them with IVF so that they can have the embryos cryopreserved and then go for a pregnancy at a future date or 2 pregnancies. But on the contrary, if the couple is planning for a single pregnancy, in this particular case, and the semen analysis still shows mild oats, then in such case, you can give the couple the option of trying either naturally for 1 or 2 cycles and then IUI for 1 or 2 cycles and decide accordingly. So it's always our responsibility to catch such cases where there is diminished ovarian reserve and advise them accordingly so that they won't land up with donor gamete at a future date and they can be biological parents with your advice. This couple, if on further evaluation with HSG, they wanted to go ahead either naturally or IUI. And on HSG, it is shown like a bilateral proximal tubal block. So how do you proceed further for them? So since they are planning either for IUI or a natural conception, we might have to repeat either SIS or fallopian tube cannulation and see if the tubes are open and then proceed accordingly for such cases. So whenever young couple comes to you with a shorter marital life, never deny fertility evaluation, always conduct one basic preliminary evaluation, and we don't know what things we might catch up at that time. This is about a 30-year female married to 35-year male for 5 years, and the previous evaluation shows patent tubes on HSG. But the TVS currently shows bilateral adherent ovaries with a right endometrioma 2 cross 3 centimeters in size with a reasonably good AFC. So what do you advise for this couple? This couple, we have to look for the basic semen analysis, and if it is found to be normal or with a minor moderate abnormality, she is a candidate for IVF because there are adherent ovaries with an endometrioma which goes more in favor of severe endometriosis considering their marital life of 5 years with a reasonably good AFC. So the right endometrioma 2 cross 3 centimeters, if the ovarian reserve was poor or moderate, then you would have thought about given an option for endometrioma excision and then see based on that. But since the AFC is reasonably good for couples whom you are planning with IVF or ICSI, there is no need to remove an endometrioma unless the issues are severe pain or inaccessibility of the follicles during oocyte retrieval. So she can be taken up for IVF based on the accessibility of the follicles. And this is a case of a 28-year-old female married to a 31-year-old male for 6 years in a second-degree consanguineous marriage, and she had a history of 2 missed miscarriages followed by the birth of a male baby who dies at 1 year of age due to spinal muscular atrophy. So the couple were advised genetic counseling after that, and on this evaluation, they were found to be heterozygous carriers of SMN1 exon 7 and 8 deletion. Later on, she conceived naturally after this evaluation, and which on amniocentesis was found to have similar affection. It had the same as SMN1 exon 7 and 8 deletion, and the pregnancy was terminated. So how do you proceed for such case? So for this specific case, you have to give the couple the option of trying with their own gamete versus trying with donor gamete. So they can always try naturally, but the chance is that they might land up in a similar condition wherein the chances are explained accordingly in genetic counseling. But to avoid that and to facilitate a normal pregnancy in such cases, we have to give them the option of IVF with PGT. I have two couples with similar picture. One of them opted for self gametes, wherein stimulation was done for the female partner, and the blastocyst which is formed, it was sent for PGT-A and PGT-M, and a single euploid normal blastocyst without the mutation was found, and this was transferred, resulting in a live birth. On the contrary, the other couple, they opted for donor oocyte with husband sperm, which reduces the chances of this mutation being expressed in homozygous form. The couple had a twin pregnancy with two healthy babies. So it's always our responsibility to give the couple the option to decide whether to go ahead with self gamete or a donor gamete. The path might be slightly difficult with the self gamete, but for those wanting to have a biological child, you might help such couples go with treatment at an early date so that they can have a successful pregnancy. So in such cases, we have to advise the couple accordingly and decide. So this is the other side of the stimulation chart, wherein the details of the women and the ID number are noted. The diagnosis, the indication for which the IVF is being done are to be noted, and the protocol, wherein the ANTAC or long agonist protocol or mild stimulation IVF, what is being done are to be noted here. And pre-treatment, if any, like estrogen pre-treatment or coenzyme Q, testosterone, which are given, are to be noted here. And at the start of stimulation, the baseline hormones like estradiol, LH, and P4 are to be noted. And if any hormones are repeated on the fifth or sixth day of stimulation, they have to be made a note of. And pre-trigger and post-trigger hormone levels are noted accordingly. And the type of injection which is being given, like FSH or HMG or Pergoveris, which is being given, has to be noted here. And if there is any plan for PGT, like PGT-A, which is advised in view of advanced maternal age, has to be made a note of. And male factor, if any, like preliminary semen analysis parameters have to be noted, and the source of the semen, whether self or donor or surgical sperm retrieval is planned, or semen sample in freezing, which is being used for this current cycle of stimulation, or microfluidics for semen preparation. All these have to be made a note of the stimulation starts. And this is a chart for folliculometry, wherein you mention the date here and the stimulation day, which is one, and accordingly the scan findings on the day of the scan have to be jotted down here. Endometrial thickness, and what are the units of gonadotropin like FSH, HMG, what units are given on each day has to be mentioned accurately. And whether the protocol is progesterone pumped ovarian stimulation, what's the dose of progesterone, whether that is an antag, what's the dose of antagonist and from which day it has started, and agonist, dose of the agonist have to be made a note of clearly. And whether growth hormone is used during stimulation, like especially in those cases with the previous poor ovarian response or diminished ovarian reserve. In such cases, growth hormone 4 or 6 international units is given either at the start of the stimulation or accordingly after the stimulation starts, based on the sizes of the follicles. And the trigger, which is decided, whether that is HCG or an agonist trigger, has to be mentioned, and what is the time of the trigger and date are to be noted. Accordingly, the oocyte retrieval date and time are to be noted based on the trigger timings, and how many oocytes are retrieved and how many are M2, and what is the fertilization stage, and number of embryos for day 3 and day 5 are to be noted. Finally, the total dose of gonadotropins given has to be made a note of. And all these stimulation chart gives us an idea of how to proceed further for this patient. In case we have many frozen blastocysts for this patient, the couple can directly go ahead with frozen embryo transfer in case they land up in implantation failure, or in case we get lesser number of embryos for this cycle, this stimulation chart helps us to plan the coming cycle of stimulation for the same couple to have a better response in the coming cycle. So this is about the IVF card. So thank you. If any doubts, you can just ask me.